So again, we are continuing genitourinary fistula as in the previous video, but for this very episode, you are going to look at the more explanation about the dye test and the three-swab test. We shall look at the treatment of vesco-vaginal fistula, then the specific advice you can give to a vesco-vaginal fistula patient, then the preventive measures and also the complication. So here we are looking at now the three-swab test. And when we talk about this three-swab test, what does it mean? We are going to have three swabs inserted in the vagina, and these ones are going to help us confirm the presence of which part is leaking and to help us diagnose the type of fistula. So these three swabs are going to be placed at different points in the vagina. And as we are going to explain, these ones will help you to diagnose ureterovaginal fistula, urethrovaginal fistula, and vesco-vaginal fistula. So what do we do when you are using a three-swab test? We get 3 cotton swabs and we place them in the vagina, one near the vulva level at the vault, another one in the middle, and another one above the inference. So after putting these 3 swabs at those different levels, one at the vault, another one in the middle, and another one above the inference, we put a methylene blue, and this is the dye, and is instilled in the bladder using a catheter. And the patient is asked to walk for 5 minutes. So after putting this dye, which we have called methylene blue, it is blue in color, this patient is going to walk for 5 minutes and will come back, and we put this patient, we tell him to lie down for inspection. And as we remove these 3 swabs, this is what you are going to observe. If uppermost swab is choked with urine, but unstained with dye, then we are going to think of this person having a ureterovaginal fistula. The uppermost swab is soaked with urine, but is not stained with dye. We shall talk of a ureterovaginal fistula. Then, if upper and lower swabs remain dry, but the middle swab stained with dye, that one we are going to talk of vesco-vaginal fistula. Then, lastly, if the upper 2 swabs remain dry, but the lower swab is stained with dye, then we talk about the diagnosis being ureterovaginal fistula. And that's how we use a dye test to confirm the presence of these 3 different fistulas. How are we going to treat the person with a vesco-vaginal fistula? We can do conservative treatment, and occasionally we say that genitourinary fistulas may spontaneously close during continuous bladder drainage using an indwelling catheter. Most times, if the fistula is small, these people, when you put a catheter for continuous bladder drainage, we can have this fistula close without operation. And that's the conservative management that we can do for someone who has a fistula. And we are saying this will help depending on the size of the fistula. When the bladder is contracting, it can end up closing this fistula. Then we have also the surgical treatment. And we are saying they have general principles if you are to do surgical treatment, and they are saying the fundamental principle of repair of vesco-vaginal fistula includes 1, appropriate pre- and intraoperative care. That's the first principle. There is timely repair. That's the second principle. There is multi-layer, tension-free closure, assessment of adequate surrounding tissue, viability, and postoperative bladder drainage. So what do we talk about bowel preparation? We are saying it's more important, especially for rectovaginal fistula than vesco-vaginal fistula. Enema and so on, we shall focus it if you are going to repair a rectovaginal fistula than a vesco-vaginal fistula. So we are saying for vesco-vaginal fistula, we just encourage the patient to defecate before operation, which is not the case for rectovaginal fistula. Even when the patient reports that is from defecating, enema must be done. Then you are saying the patient could be allowed to drink up to 4 hours before the operation. As you know well, what is easily absorbed within 2 hours to be absorbed, so the patient can be drinking up to 4 hours before operation. Because most of these patients, even they are dehydrated because they have lost a lot of fluids during that continuous leakage they have been having. So we said there's another principle, which is timing of repair. Traditional teaching recommends delayed repair of fistula. At least we should spend 3 to 6 months after injury. And this will say that if someone has gotten injured and now has a fistula, we should allow him to go home and at least spend 3 to 6 months. That's when he comes for repair. However, early surgical intervention of an uncomplicated fistula is recommended, especially nowadays, to reduce social and psychological patient distress. So what are we going to do? Fistulas identified within the first 24 and 48 hours postoperatively can safely be repaired immediately, and these have reported a success. So it is my role as a health worker and you as a health worker to see that you diagnose keenly these fistulas, because once it exceeds 48 hours before you have diagnosed the fistula, then they are going to wait for 3 to 6 months before they can come for repair. Let us do our part to help the Ugandans. What's the postoperative care we do for people who have undergone fistula repair? 1, we offer prophylactic antibiotics. An antibiotic of your choice can safely be offered. Metronidazole, ceftriaxone can safely be used postoperatively as for prophylaxis. Then there is continuous bladder drainage, and this has to take 14 days. And we have to open the tube. It is open tube drainage. So you don't have to kink the catheter or the tube on the urinary bag. It has to be continuous bladder drainage. And this will spend 14 days. Then we shall allow the patient to drink up to 5 liters of water per day. And lastly, we make sure that the bed is dry. So in short term, postoperatively, what is specific for a person who has undergone fistula repair? We need to create a 3D chart. And this chart just has 3 Ds. One standing for drainage, drinking, dry bed. 3D. Is the patient drinking? Yes. Is the catheter draining? Yes. Is the bed dry? Yes. That's good progress. And that's the role of a nurse, to see that he monitors the 3D for a person who has undergone fistula repair. So before sending the patient home, what are you going to do? We are saying repeat the dye test, because once you repeat the dye test, you will be able to notice whether the fistula completely closed or it is still there. Another thing, when you remove the catheter, now after 14 days, you must tell the patient that we should tell the patient that if she doesn't pass urine in the first 4 hours, she must tell you. Because this one will mean that more urine is now being stored in the bladder and it's going to make it stretch and hence it may rupture the repaired fistula. Then you are saying most cases it is a good idea to let the patient stay in the hospital for more a few days after we have removed the catheter. And the reason is we want to monitor whether there is an infection that has occurred, or if leaking, we are saying you can cure them with catheter, and we say that we reinsert the catheter for the first month. Advice on discharge: when you are managing fistula patients, we are saying we tell them to pass urine more frequently. They should now not keep urine in the bladder. Once they feel a small urge, they go and pass urine. This prevents the bladder from stretching more and hence may rupture the repaired fistula. Another thing is tell them these mothers should avoid coitus for the first 3 months post-operatively, because with coitus, they are likely now to have this fistula also gap and hence shall have done nothing. Then another thing, just tell the mother at least to spend a year before he can get pregnant. This one will give time for the part that was repaired to heal completely. And you are saying if conception occurs, this mother should report the hospital and must go for mandatory antenatal checkup and should deliver in the hospital. And we are saying a successful repair should have an abdominal delivery. We are saying once we repair the fistula, most cases, the patient has to be done cesarean section. Thank you for listening, but this is our last part when you're looking at the preventive measures, then complication, and we end. So how do we prevent a fistula from occurring? One, adequate antenatal care. This one will help to find an abnormality. Then proper monitoring of the mother. When you're using a pathograph, there is continuous bladder drainage. Ensure that during monitoring of labor, there is continuous bladder drainage. And in the case of surgery, avoid injury to the bladder. Complications: if a fistula is not managed, one, many people can end their life, which are calling suicide. If they don't do so, they appear isolated, they hide from others. Most of them have low mood, which is depression. Others develop foot drop because of dehydration. Then there is financial stress because most of them don't have money. They would have gone for repair. Then there are many divorce them, and we are saying they are more sick and they can easily die because of the complications of dehydration. Thank you for listening. Share the video with your colleague so that he can get all this information from you. And ensure that you share the channel to your friends. Thank you.